In this lecture, we'll talk about the integumentary system, which is largely the skin, but rather than just calling it the skin, there's other parts that go along with the skin. So we're going to find, for example, hair and nails. We're going to find sweat glands and sebaceous glands and things like that. So when we put all of that together with the skin, we call it the integumentary system. And what's the importance? I think some of these are pretty self-evident, or I'm sure we've all thought about these, and some of them may surprise you. So protection, of course, is a big part of the integumentary system. If you think about what your body comes in contact with every day, either in the atmosphere or things that you touch, if any of you have been to Walmart or Target this week, who knows what you've touched that other people have touched. And so your skin acts really as that first line of defense. It acts first as a physical barrier so that it actually prevents a lot of bacteria, viruses, things that are on the outside world from entering the inside of your body through touch. So there's a physical barrier there. But there's also immune cells that are embedded in your skin so that if things do make it past that physical barrier, you've got kind of your first responders of the immune system often hanging in and around the skin. There's also protection, however, I think most of us probably don't think about, from dehydration. So your body is about 2/3 water, and it's your skin that actually holds that water inside. If you lose skin, let's say you have a severe burn, and that layer of skin is lost in a large part of your body, the number one kind of acute problem in that circumstance is dehydration. Your fluid will just start leaking out of tissue, and because there's no skin to hold it inside the body, all of that fluid will run out of the body. And so one of the things that we have to worry about with people who have severe burns is getting them tons and tons of fluid. I mean, we give them liters and liters and liters of fluid in the first 8 hours, first 24 hours, and that's one of our top priorities. There's also the issue of protection there as well. Since they've lost all that skin, let's say in a burn, there's no physical barrier to bacteria. So the other common complication is infection along with dehydration. So in addition to protection, there's thermoregulation. And maybe you've thought of this when you've been in the gym or you've been on the field or on the court and you've been hot and you've been sweating and you kind of get the reminder, hey, this sweat is kind of helping me cool down. So certainly through sweat and sweat glands, the body uses the integumentary system to help us get rid of excess temperature. But it's actually more complicated than that. There are blood vessels running throughout the dermis of the skin that can either vasoconstrict or vasodilate, and that will also help maintain a steady temperature in the body, and we'll talk about that a little bit later. Vitamin D synthesis, maybe most of you guys are aware of this now, but most of the vitamin D that we need in a day can be created through the contact of sunlight with our skin. There are enzymes in our skin that, when activated by sunlight, help produce vitamin D, and you don't even need that much time out in the sun. I forget the exact numbers, but it's like, I don't know, 20 or 30 minutes a day of good skin exposure in full sun, and you will have made all the vitamin D that you need for the day. So a lot of that happens through the skin. Of course, we can also eat vitamin D through things that we eat. And then sensation, I'm sure you've all thought about when you've gotten a cut, for example, or when someone taps you on the shoulder. All of these are functions of the integumentary system. You have special sensory receptors in the skin that help you feel pressure, touch, pain, temperature, things like that. Excuse me. One of the main reasons that we study the integumentary system in the skin kind of separately, and we don't just brush over it and say, hey, the skin's good for you, protect your body, is because what you'll find clinically is that there are tons and tons of problems that come up in the skin. So as you guys move on from this course and from physiology, and you move into pathophysiology, you start doing clinical rotations in hospitals and clinics, you're going to start to see a lot of problems with the skin. Cancer is the picture shown here. That's a basal cell carcinoma of the toe. Clearly, this person has let this go for way too long. But skin cancer, of course, is a very common cancer. It's one of the most common cancers in the world. Thankfully, most of it is not deadly, although melanoma can be fatal, but it is super common and something that we need to look for and treat. Infections in the skin, cellulitis and abscesses, I see, I would bet 2 or 3 in every shift in the emergency room. I see 2 or 3 patients that have some kind of infection of the skin. We're all going to develop at some point dry skin and wrinkles. That may be more distressing to some than others. There are skin diseases like eczema and psoriasis that cause itching and dryness of the skin, discoloration of the skin. Of course, scar tissue, if you've ever cut yourself badly or had surgery. Acne, which I have a teenager at home, and that can be, quite distressing, especially if it gets to be more severe. Hair loss, which I am personally experiencing as I get older, and there are lots of causes of hair loss. We'll touch on a few of those. And then just nail changes, pitting of the nail, spooning of the nail, splitting of the nails, nails that crack too easily. These are all problems that you'll see quite regularly in clinical practice. So as we look at the integumentary system, we're going to break it down into skin, and then skin will be broken down into basically the epidermis, that's the top layer, and the dermis, and then the subcutaneous layer we'll talk about briefly. And the accessory structures, we'll talk about hair, glands, and nail. So let's start with the epidermis. That's the top layer of skin. There are several specialized cells that can be found in the epidermis. The first one mentioned here is keratinocytes, and they just get their they get their name from the protein that they create. So keratinocytes, remember that ending C-Y-T-E-S? That just means cell. So these are cells that produce keratin. And keratin is a protein that is kind of layered into the outer parts of our skin, and they add a toughness, a barrier to the skin so that things can't get through, so that we don't get damaged easily. And what we'll see in future slides here is that keratin is particularly heavy in what we call thick skin, which would be like the palms of your hands and the soles of your feet, places that are in contact regularly with the outside world and might undergo more wear and tear, more pressure, more stress. They have more keratin. So keratin is this protective protein, and it's made by keratinocytes. Okay, so melanocytes, again, if we drop off the sites, we see melanin, or most of the word melanin. So melanocytes are going to produce melanin. Melanin is used to create skin color, but its primary function is to help absorb some of the ultraviolet radiation from the sun in order to protect our cells from contact with that dangerous radiation. So the melanocytes seem to absorb some of that dangerous radiation from the sun. Merkel cells, this is a type of cell that provides sensation in the skin. There are other sensory cells as well in the skin that we'll touch on briefly. And then Langerhans cells, or sometimes these days is more commonly called dendritic cells. These are the immune cells in the skin. And I had mentioned this previously, that let's say you have a cut or you have an opening in your skin, so that physical barrier has been damaged, and bacteria start to enter into the deeper areas of the skin, trying to enter the body. These dendritic cells, or Langerhans cells, are some of the first cells that will identify and trigger the immune response to try and kill that bacteria or isolate that bacteria before it can enter the body and do more damage. So when we talk about the skin and we separate it into 2 primary layers, the epidermis, which is the kind of the part that we all see, it's the top layer of skin, and then the dermis would be the lower. So we're going to see this and we've already seen this, but this prefix epi again comes from the Greek, which means on top of or above. And so the epidermis is what is on top of or above the dermis. So it's the outer layer of skin. But the epidermis itself can be separated into 5 of its own layers. And so we're going to go through each of those here in the lecture, and then in class together we'll actually look at slides and we'll try to identify the layers, and I'll actually have you draw some pictures of the different layers. They're not all very visible on the microscopes that we have, but we will be able to see most of them. So we're going to start from the bottom, and then we're going to work our way up to the top layers of the epidermis. So if we start at the bottom, that's the stratum basale. And basale just has the word basal, right? And basal sounds like base. And so you can remember that the stratum basale is the base or the bottom layer. And so it's full of what we call basal cells. And so basal cells are really the stem cells of the skin. So this is where new skin cells are going to be made. And it makes sense to me that they're in the basal layer, that they're protected down deep in the epidermis so that they don't get destroyed by wear and tear and friction and touching and rubbing with the outside world. They're kind of protected in a deeper layer so that they can continue to produce new skin cells as old skin cells get destroyed or damaged. And so they're going to produce new keratinocytes. Keratinocytes are kind of the mature skin cells of the epidermis. There are also some melanocytes in the stratum basale, and there are Merkel cells that we talked about, especially in the fingertips or areas where there's no hair, and that's going to help us have increased sensation. So the reason that your fingertips are so sensitive is because of the Merkel cells that are in this stratum basale. Okay, if we go up one layer from there, we get to the stratum spinosum, and I hope we'll be able to see this in the microscope. We were able to see it on some of the slides last year. That term spinosum sounds like spine, and that's exactly where the name comes from. When you cut skin and you treat it and you fix it on a slide and you look under the microscope, that process causes the cells in this layer to kind of shrink. And then you can see the attachments between neighboring cells, and they look like little spines coming out of the cell and touching each other and holding each other. And that's where the name comes from, stratum spinosum. And so the keratinocytes there are very tightly attached with tenofibrils. That's the spiky-like attachments. And then desmosomes. Desmosomes are really strong cell-to-cell attachments, but what's unique about them is they allow for twisting and stretching without tearing and ripping. So they're very useful in tissues that need to expand and contract and move and twist and pull, because they allow the tissue to do that. They allow the cells to be a little bit flexible, but still to be very strongly held together so that they don't tear apart. So they give strength and flexibility to the skin. The stratum granulosum would be the next layer up. You can see here. That's going to be difficult for us to see on the microscope. But this is where the keratinocytes become more mature and start really producing keratin. And that keratin is going to be kind of moved up to the surface where it can serve as a protective barrier. You'll see some of the cells here beginning to die, so that really the outer layers of skin that we can touch and see, most of that is keratin and dead cells. The stratum lucidum is only found in thick skin, so this is kind of an important distinction to make here. If I, gave you a slide of thin skin, you would only expect to see 4 layers. If I give you a slide of thick skin, there should be 5 layers. The stratum lucidum is difficult to see. It's very thin. As the name suggests, it is lucent, meaning it's kind of see-through. It has a different color, a lighter color, a more clear color when stained than the other layers do. It stains poorly, so it doesn't really pick up the stain. And really, that's probably all that we're going to say about that layer. The final layer, which is the one that we're really in contact with, is the stratum corneum. And you'll see this term corneum sometimes used for thick skin. And that's especially on the palms and the soles. That's where the keratin is. That's where keratin and basically dead cells form a protective layer. You can see how thick that layer is here on the picture. This would be a picture of like the palm of your hand, for example, and you can see how most of that is stratum corneum. Most of it is lots of keratin fibers and flattened dead cells, as you can see there. You do get a little bit of perspiration through this type of skin, this layer of skin, so you can get some fluid loss, and you maybe have noticed that if the palms of your feet, or the palms of your hands or the soles of your feet have ever become sweaty or moist. That's that insensible perspiration. It's not something that can be necessarily measured, but it happens especially when we get nervous or excited. Okay, I mentioned this already briefly, thick skin versus thin skin. So thick skin is going to be found on the palms of your hands and the soles of your feet, and is going to have a very large stratum corneum, a very thick stratum corneum. Thin skin is going to be found pretty much everywhere else on your body, and you can see, look at how small the stratum corneum is there compared to the stratum corneum of the thick skin. So that's really the main difference. 5 layers in thick skin because we have the stratum lucidum, only 4 layers in thin skin because there is no stratum lucidum, and the stratum corneum is huge, very thick in thick skin, and very small or thin in thin skin. Now at the juncture between the epidermis and the dermis, which we'll talk about next, there are these ridges, or these kind of hills and valleys, if you will. You can kind of see them here. So the epidermis is this part here, and the dermis is this part here. And you can see where they connect with each other, there are these hills and valleys, or these ridges and papillae, as we would say. So what that does is it allows for a greater surface area between the dermis and epidermis, so that they can attach or adhere together better, so that it would prevent kind of sliding of the epidermis over the dermis. And so it's useful for that purpose. But what that produces, which most of us are aware of, are our fingerprints. And fingerprints are also sometimes called epidermal ridges. And those epidermal ridges are just kind of the outer manifestation of those dermal ridges and papillae underneath. And of course, these are a unique identifying factor for most of us, but they also seem to provide a little bit of extra grip when we grab things with our finger. Because of the ridges in between the papillae, it creates a little bit of suction when we grab a hold of something, and that gives us a little bit better grip than we would have with smooth fingertips, for example. Okay, skin color comes from several areas. Most of us have heard of melanin or melanocytes maybe at some point, and we know that melanin kind of is a dark, that's the last one I have here. Melanin is kind of a dark pigment, and so ethnicities that have a darker skin color, maybe from Africa or the Middle East, parts of South America, they're going to have greater amounts of melanin in their skin, so that their skin appears darker. Melanin, as we mentioned before, are produced by melanocytes. When the melanocytes, you can see in the picture here, the melanocyte is the big brown cell with kind of the extensions coming out. The melanocyte, when it produces the melanin, then stores the melanin in melanosomes. What you'll notice so I worked in Africa for many years, and what you'll notice is that even in ethnicities that have a darker skin color, they have more melanin throughout their skin. If you look at the palms of their hands and the soles of their feet, you'll find that they look very pale in comparison to the rest of their skin. And that's because there's very few melanocytes in the palms and the soles. Now, this was, for us, very useful clinically, because if we wanted to look at things like cyanosis, blueness of the skin, for example, from low oxygen, or paleness of the skin from anemia, or even jaundice in a child or newborn, it would be hard to see that in the dark skin in most of the African patients that we took care of. But if we looked at the palm of their hands, we could often see a lot of these color changes. But melanin is not the only source of color in the skin. There's a couple of other sources. Blood flow is a source of color, that's for sure, especially in lighter skinned people. If you notice, your skin, if we might say a Caucasian person is white, well, not really, right? We're kind of slightly pink, slightly yellow. It's really hard to give a color. It's certainly not white like a sheet is white or snow is white. And that's because we have blood flowing through our veins and capillaries and arteries. And that blood is going to give a reddish tint to anybody's skin, but it can be seen more prominently in lighter skinned people. If we are anemic, meaning we have low red blood cells or low hemoglobin, we might see that that skin becomes less reddish, becomes more white, and we call that pale. Let's say you have enough blood, but you don't have enough oxygen in your blood. That will turn the blood on the surface will be less red and will become more purple or more bluish, and you'll see kind of a bluish tint to the skin. We would call that cyanosis. In addition to blood flow and melanin, keratin, which is kind of the orangish yellow substance in things like squash and cantaloupe and carrots, that's also in our skin, and that's what gives the skin that kind of yellow orangish hue to it as well. And basically, keratin is eventually converted to vitamin A, so it's a precursor to vitamin A. As a family practice doctor, I kind of would not be doing my job if I didn't at least give you one slide of warning about tanning. So, of course, this lady up here, this is why everyone goes to tan. Everybody wants to have this beautiful kind of bronze-colored skin. For whatever reason, in our culture, we believe that to be beautiful. And so, people either go to tanning salons and tanning beds, or they just spend time in the sun. The danger with that is twofold. One is just, tanning may help you look like this person now, but eventually tanning is going to make you look like that person in the future. So this lady's probably 55 years old, but because she lives on the beach and has tanned, most days of her life, her skin already looks like she's 80. And that's because the UV radiation from the sunlight or from tanning beds that also use UV radiation kind of destroys the dermis underlying the skin. And when the dermis begins to get thin and destroyed, the skin kind of gets loose and wrinkly like this. Of course, the more serious problem is skin cancer, and particularly melanomas. And these, pretty much all skin cancers are, the risk of having all skin cancer is increased by exposure to UV radiation, which comes from the sun or tanning beds. But melanomas are the ones that can be deadly, and so those are the ones that we tend to focus on. So I would just encourage you to not use tanning beds. I would encourage you to wear your sunscreen when you go out in the sun, and just be happy with the skin color that God has given you, and save your skin for the future so you don't end up looking like that, and prevent skin cancer by using sunscreen or staying out of the sun. So if we move deeper into the skin, below the epidermis, we will find the dermis. And the dermis, we're going to see, really has two of its own layers. So we had mentioned 5 layers with the epidermis. Now we're going to talk about 2 layers here in the dermis. And the 2 layers are the papillary layer, and that's going to be kind of the upper layer of the dermis. And then the reticular layer, which is kind of the lower layer. And then we're going to talk here about the subcutaneous layer, which technically isn't part of the skin. It's just below the skin, hence the name subcutaneous, cutaneous meaning skin. But it's an important part that's attached to the skin, and we use it clinically, so we'll talk about that briefly as well. Excuse me. So the papillary layer we already kind of mentioned with the ridges and the papillae. This is the layer that's anchoring the epidermis to the dermis so that the dermis doesn't slide around on the outside of your body but is attached firmly to deeper tissues. This happens at the papillary layer. And there is some vascularity there, meaning there are some capillaries that run through that area that we're going to see the body's going to use to help regulate temperature. The reticular layer, which is attached to the papillary layer, is made up of a different kind of connective tissue. If you remember the connective tissue lecture and lab that we did, there is a dense, irregular connective tissue there that adds some strength and some elasticity so that there can be some stretching of the skin without tearing. That's going to largely come from this area of the dermis due to the type of connective tissue that's there. Just a brief word on wrinkles, stretch marks, and tension lines. Wrinkles, I already mentioned, really are formed from either thinning or destruction of the dermal layer, and this occurs naturally as a part of aging, which is why we get more excuse me, why we get more wrinkles as we age. But this can happen prematurely through time spent in the sun and to UV radiation. Stretch marks are common, especially in pregnant women, because they have a rapid enlargement of their abdomen over a short period of time as the baby grows. If you're someone like me who has changed weight quickly, maybe gained 20 or 30 pounds here in your first year of college or your first couple years of college, or for me, when I got married, for example, you may find some stretch marks on your hips and your abdomen. And that's really just from stretching of collagen and elastic fibers. So because those fibers can withstand a little bit of stretch and can kind of spring back to normal size, but when they get overstretched, so kind of a rapid weight gain over a short period of time, they really get kind of destroyed, and they lose their bounciness. They're not able to spring back, and so you end up getting these stretch marks as a result. Tension lines are actually just part of how the skin grows as we develop, from a fetus to an infant and to an adult. As we grow and our skin grows, it grows along these tension lines, and that's partly based on fascia underneath and muscle and different attachments of tendons and aponeuroses and other things. But you get these tension lines in the body, and this is important clinically because we will often use those tension lines in surgery to reduce what a scar looks like. So let's say, for example, if we pull up here, we wanted to take out a lump, let's say from here. Let's say there was an enlarged lymph node and we needed to do a biopsy, and so we had to cut a small incision. Rather than cutting our incision this way, which would go against the tension lines, we may choose to cut the incision this way so that when we take out the lymph node and we sew it back up, it will heal naturally along the tension line, and that will cause less scarring. If we, as another example, look down at the abdomen, for example, when we do a C-section, and it's kind of hard to see only because they're giving you this guy's bottom as well, but when we do a C-section on a woman and we want to do a lower incision, we do one that kind of looks like this, and that's just so that we catch, as much of the tension lines as we can, so that as it heals, you almost can't even see the scar as it kind of blends into the tension lines. So those are important, especially for surgeons. Okay, so back to the dermis that we were talking about. If we look at the vascular supply of the dermis, we can see that there are several plexuses. A plexus, and we're going to see this word a few times in anatomy, a plexus is just kind of a congregation of blood vessels. Sometimes it's a congregation of nerves, all in one area. So we have a cutaneous and a subpapillary plexus, you can see, And I'm not really concerned that you learn the difference between cutaneous plexus and subpapillary plexus. I just want you to get the idea that there's a lot of blood vessels there in the dermis, and that your body uses those blood vessels in order to help regulate the temperature of the body. So if your temperature is too high, let's say you're running a fever, or let's say you're exercising and you're using your muscles and you're making ATP, and the byproduct of all of that metabolism is heat. And so you've got too much heat in your body. So your body has to find a way of getting rid of that heat, and it does it through several ways, but one of the ways it does that is by dilating the blood vessels close to your skin. And that allows more blood to flow to those areas. And because the blood is warm, because the body's warm, it allows the blood to be cooled as it comes to the surface of the skin and comes in contact with almost always a cooler environment. On the other hand, let's say it's really cold outside and you don't want to lose excess heat, these plexuses will do the opposite. You will get vasoconstriction, you'll get kind of clamping down of the blood vessels that go to the extremities, so that you don't have much blood flow going to those areas, so that you don't have blood in contact with the cold environment, and that way you can conserve body temperature. So we call that thermo, as in heat, and regulation. So I want you to learn these two terms, vasodilation and vasoconstriction. So vaso just refers to blood vessel, and dilation, is opening, and constriction, is kind of making smaller. So vasodilation would lead to cooling of the body, and vasoconstriction would lead to conservation of heat. Okay, the dermis is also our source of sensation for the skin, and there are multiple specialized nerve cells and sensory cells in the dermis. Some of them help us feel light touch, some of them help us feel temperature, some of them help us feel pain. And I've decided not to have you memorize. There's actually charts in your book. If any of you have the book and you go to it, you'll find a table, a chart in there with all the different types of sensory cells and what kind of sensation they give you. For example, Meissner's corpuscles, Pacinian corpuscles, nociceptors, things like that. We'll talk about some of them in physiology. For now, I just want you to understand that these sensory cells are in the dermis, and that there are multiple types of sensory cells, and they each give you a different type of sensation. So you don't have to learn the names here, just understand that concept. Okay, so we had epidermis, and then we had dermis, and that's really the skin. But right under the skin, attached to the dermis, is a layer called the subcutaneous layer. And this is composed of loose connective tissue, a type of areolar connective tissue that's really high in adipose tissue. You can see in the picture all of these kind of yellow circles. Those are all adipocytes or adipocytes, full of lipids, fats. And that layer of tissue gives an extra layer of kind of cushion, protection. It also gives insulation because of all that fat. It helps kind of conserve some heat, so the more fat you have there, the less cold that you'll feel. It's a layer of insulation. But it also serves as a source of energy because the lipids found in the adipocytes can be broken down into energy. So a lot of times excess energy is stored as fat, and it's stored in that subcutaneous layer. Clinically, it becomes important because there is some vascularity there. You can kind of see some of the blood vessels down in that layer. And so a lot of times we will put medicine in the subcutaneous layer and have it be absorbed there. Probably the most well-known medicine that goes in the subcutaneous area is insulin. So type 1 diabetics that have to give themselves insulin daily, they actually inject it into this subcutaneous layer. There's other medicines like blood thinners such as heparin and Lovenox that we also inject into the subcutaneous layer. So if we move on from skin to the rest of the integumentary system, we'll look first at hair, and then we'll look at different glands and nails, also as we finish out the lecture. I'm not going to say a lot about hair. I want to talk a little bit about the function of hair and the anatomical structure of hair. I'm not going to have you memorize all the parts. It's much more complicated than you probably ever thought it could be. I'm just going to have you learn a few terms that you may see again in the future. So if you look here at the picture, you can see that this is the hair structure down deep in the dermis and the skin, and then the hair would kind of come out onto the surface. So as we look at the hair kind of from its base, which would be down here, we can see a few parts that are maybe important to at least learn their names. And then we'll kind of look at the name of the shaft of the hair. So the hair papilla is going to be at the base, and that's going to be where the nerves and blood vessels are. That's right down here. And that's just important because if you've ever had your hair pulled, you know that that hurts. And the nerves that help you feel that are down there at the papilla. It's also where the blood vessels are that bring fresh blood, circulation, nutrients, oxygen to the matrix, which is growing new hair cells. So you need to have a blood supply to feed those cells in the hair matrix. So you're going to see the matrix is where the epithelial cells are, which actually form the hair. The hair bulb, I'm not going to make you learn that. That's just a layer surrounding the papilla. The hair root is basically from here to about halfway up. And then from halfway up to outside is going to be the hair shaft. So make sure you know papilla, matrix, root, and shaft. And we don't usually think about the function of hair very much, but it's actually important. I mean, I think when we look at animals, we see that their hair, their fur, is obviously helpful for warmth. And that's true to a certain extent, although most of us don't have enough hair to keep us warm without clothing. But the more hair we have, the warmer we will feel, typically. But if we think of kind of maybe more functions in us as humans, we can look at where hair is most often found. So, for example, on the head, your scalp is a very sensitive area. There's lots of nerves there, and that's because it's an important, your head is an important area of your body, and so you want to know if your head is being injured. So it's very sensitive. It's also very vascular. If you've ever cut your scalp, or seen someone else who's, maybe banged their head, fallen, and split the back of their head open, you can bleed a ton from a scalp laceration. And that's because it's just so vascular. And so the hair kind of acts as a buffer between the external environment and that scalp, which is so sensitive and so vascular. So I don't know how many times you've bumped your head on the, let's say, the edge of a cabinet, or who knows what, when you were younger, on the edge of a table standing up and things like that. If you didn't have hair to cushion, you would get a laceration and bleed. It would be very painful. And so the hair acts as a protection for your scalp. I'll just say from personal experience, when I was younger, I had much less difficulty damaging my scalp. I had lots of hair, was able to really get great protection. Nowadays, I have almost no hair, excuse me, on the top of my head, and it's much more susceptible to injury. Let me grab a drink here. In addition to protection of the scalp, it's also a type of protection for other parts of our body. For example, hair in your nose. As you breathe things in from the atmosphere, sometimes there are things in the air that we really don't want to enter our lungs. There might be pollution, particles, dirt, bacteria, funguses, or fungi, all kinds of things in the atmosphere that we would rather not enter our lungs. And there are several mechanisms that we'll talk about in the respiratory system that your body uses to prevent entrance of that, but hair is one of them. So we have quite a bit of hair, and you may know this or not, but as you get older, you seem to get more hair in your nostrils, and it functions as a barrier, as a way of kind of a first line of defense of weeding out at least larger particles from the respiratory system. Your ears have a similar network of hairs to prevent things from entering the ear, and your eyelashes. Maybe you never really thought about why you have eyelashes. You have your eyebrow, and the kind of that part of your forehead kind of projects out away from the eye, kind of provides like a covering over the eye, and the hair there on the eyebrow collects things that might fall from above us. If you've ever been working on something in the ceiling, maybe drilling into the ceiling or drilling into a wall above you, and some of that drywall or wood comes spraying off, a lot of it will get caught, for example, in your eyebrows instead of going into your eyeball. And the same thing with eyelashes. Anything that kind of makes it past the eyebrow and falls down towards the eye may get caught in the eyelashes. So they act as a protection to keep things out of sensitive areas. They can also function as an early warning system. I mean, on a larger, not a larger scale, but maybe a more easy to understand scale, if you think of something like a cat and a cat's whiskers, a cat can use those whiskers to see how wide an opening is to see if their body will fit, for example. Well, hair for us functions as a warning system similarly. I thought about this when we were in Africa. In America, we don't worry too much about mosquitoes most of the time because they don't typically carry dangerous diseases, although these days you can get triple E and West Nile virus and Zika and things like that. But in Africa, we were worried about mosquitoes mostly for things like malaria. And so the hair on your skin, for example, would serve as an early warning system. If a mosquito lands on you and moves the hair on your arm, you're going to feel the movement of your hair, and that's going to trigger you to take a look at your arm and hopefully either kill or at least shoo away that mosquito before it can bite you and cause damage. So, and this way, the hair serves as kind of an early warning system. There is also, we talked about kind of the hair and what makes up the hair, but there is also a muscle attached to many of our hairs that when it contracts makes the hair go from kind of laying flat to standing up straight. And that's called the erector pili muscle. And that's what gives you goosebumps or makes your hair stand on end. And we know that that occurs most often from emotional triggers, usually anxiety, fear, stress, shock. Okay, there are multiple hair types. I'll just mention briefly what's called lanugo. This is hair that's really only found on a newborn baby, and I mean newborn, like just born, and within the first week or so, that hair begins to fall off. So even after the first couple of weeks, there's really no more lanugo hair. It's really fine. It's funny if you see a baby that's born a little bit older. So let's say the baby's born at 41 weeks. They may have more of skin, more of this hair on them, and they can look quite hairy when they come out of the womb. But not to worry, all that hair will fall off, and it's really only something seen in those first few days. Vellus hair is the hair that covers most of our bodies. Now, I would say that especially if you're a female, most of the hair on your body is in vellus form. It's kind of a fine, lightly colored, softer hair. It's testosterone that converts vellus hair to terminal hair, which is the third one. And because women have less testosterone in general, they have less terminal hairs. And so men tend to have more terminal hairs. Think about facial hair in men, beards and mustaches. That's terminal hair. Most of the hair that you can visibly see on the head is terminal hair, although there is vellus hair mixed in with terminal hair on the scalp. So vellus hair is kind of the softer, lighter colored hair on most of the body. Terminal hair is the thick, coarse, darker hair armpits, pubic area, eyebrows, scalp. And, you know, on men, terminal hairs are mixed with vellus hairs all over the body. Hair color is a pretty complicated genetic system that's not completely understood. But it comes from melanin that's produced by melanocytes in the papilla of the hair shaft. And there are a couple of different types of melanin in hair. There's one for brown or black, kind of dark colored hair. There's a different melanin that's produced for orange or red color hair, and it's the relative amounts of each of those pigments and maybe even other pigments involved as well that ultimately determine hair color. Now, hair growth and hair loss, I wanted to mention just briefly. Hair, most of the hair, if we're talking about the hair on your head in particular, most hairs will grow for 2 to 5 years. Once they're kind of mature, they will become what we call club hairs, and then those hairs will eventually be dislodged from the follicle and fall out. And so really on any given day, we can lose 50 to 100 hairs from our head on any day. So sometimes when a patient comes in and they're complaining of hair loss, sometimes it's just this normal 50 to 100 and the person is just maybe overly anxious about the hair loss. If they're losing more than that, or if we're seeing bald spots on the head, then obviously this is more than the normal daily hair loss. So what happens is you get new, once that hair kind of gets old and dies, the new hair begins to grow underneath it and begins to push that club hair out until it eventually falls out. Now, there are some things that can make that occur faster, and that would be things like stress. Some drugs can do that. But there are also some processes, whether it's other drugs or autoimmune diseases, that actually attack the hair follicle and prevent those follicles from producing new hairs. So when the old hairs fall out, new hair is not produced, and you end up with bald spots. There's actually a ton of causes of hair loss. And male pattern baldness is probably the most common cause of hair loss, something that I am intimately aware of. And what happens in male pattern baldness, there is some kind of overall hair loss, that's true, but people who have male pattern baldness are not actually completely bald. They may look bald, especially from a distance, but if you get close to them and if you're brave enough and they let you touch the top of their head, you'll find that even though it looks bald, you'll still feel hair up there. There's kind of a peach fuzz of hair up there. And what you're feeling is vellus hair. So we talked about how usually most of the hair on the head, on the scalp, is terminal hair. But what happens in male pattern baldness through production of an androgen, a testosterone-like hormone, is that it kind of shifts these hairs. It kind of turns off the making of terminal hairs and makes them produce vellus hairs. So it's not that all the hair is gone. It's kind of a misnomer to call it baldness. It's more that the hair has been changed. So what used to be terminal hairs are now vellus hairs. Now over time, with enough of this androgen activity, you'll actually lose most of the hair and you may become completely bald on the top of the head. Okay, I want to talk about some accessory glands. What we're going to talk about here are what we call exocrine glands. Those are glands that secrete a substance that is eventually secreted outside the body. Endocrine glands we'll talk about later. Those are glands that produce, let's say, hormones that are secreted into the blood. So that's a kind of a different topic, and we'll talk about the endocrine system separately. These are exocrine glands, and so they're going to produce a substance that gets secreted outside the body. And we're going to talk about really two primary types of glands, sebaceous glands, which produce like a moisturizing oil for the skin, and then sweat glands. Within sweat glands, we'll talk about two separate ones. So sebaceous glands are sometimes grouped in together with sweat glands, but they're not really producing sweat, and they're not really producing their substance for the purpose of temperature regulation. They're producing an oil, really. And that oil is both a protection. There's some antibiotic properties to that sebum that's made, that oil that comes from the sebaceous glands. But they're also producing this sebum as a protective layer from dehydration. And so when you wash your hands too much, for example, in water and soap, you strip the sebum from your hands and your hands get very dry. So as you can see in the picture, this part of the apparatus is where the sebum or oil is being produced. And then you've got the hair follicle hair, and you would have kind of the hair shaft coming out of there. And so you can see that this gland can produce this oil, which can kind of come up with the hair, coat the hair, and then kind of form a coating around the skin as well. And this is secreted, the oil, the sebum, is secreted by holocrine secretion. If you remember when we were talking about epithelial cells, this is the type where the cell itself actually destroys itself and kind of releases what was inside, and then new cells are formed, which can form more of the oil. So holocrine secretion by sebaceous glands. Sebaceous glands are most often what causes mild acne. So when those oily glands get plugged up, either from dirt, or sometimes there's just an overproduction of the oil and it gets kind of thick and gets stuck, and it is related to hormones, which is why it happens more during the teenage years, through testosterone and other androgens. And so they can get blocked. And when they get blocked, occasionally they get infected because bacteria likes to grow in that warm, oily substance. And this is why if you've ever had your acne treated, sometimes the doctor will give you an antibiotic either in a cream form or to take by mouth to try and help the acne calm down. You can see there's a high concentration on the face, the back, and the chest, and that's where you often see acne as well. Okay, so that was sebaceous glands, really more for an oily protection. Sweat glands are used to help us reduce heat in the body and to remove the body, to remove some toxins from the body as well. There's two types. There's apocrine sweat glands and there's eccrine sweat glands. We're going to start first with the apocrine type. These are what I call the stinky sweat glands. So you can just think about the areas of your body that get more smelly when you sweat more. So that's like the armpit, that's the groin. These are the areas that have apocrine sweat glands. It's kind of a misnomer because it's not apocrine secretion. It's actually eccrine secretion, if you remember from the previous lecture. So even though it's called apocrine sweat glands, the type of secretion is actually eccrine secretion. And, these don't really start secreting until puberty. And this is why smaller children don't really smell when they get sweaty. It's not until you become a teenager and these glands begin to turn on and really produce a lot of sweat that you start to produce sweat from these glands and start to smell. Sorry, excuse me. These are also released, glands also release pheromones, which can attract members of the opposite sex to one another. Now, in other animal species, the pheromones seem to be much stronger, but humans also seem to secrete pheromones that may play a part in attraction between different people. The sweat glands that most of us think of, most of the sweat glands in our body, these are eccrine sweat glands. These are the ones, excuse me, if you go back to the picture at the beginning of the lecture of Serena Williams, and she's kind of glistening all over her body from the sweat because she just finished a tennis match. Most of that sweat is from eccrine sweat glands. Sometimes they're called Maricrine sweat glands. We do have a lot of them on the palms and soles, which I had mentioned previously, and they produce sweat. This is typically for thermoregulation. It's to help us release heat if we're exercising and we need to get rid of some heat, or if we're just hot. For example, if you've ever sweated out a fever, or you say, "Oh, my fever broke and then I started sweating," well, that's your body's way of getting rid of the heat that built up during the fever, is by getting the heat released through sweat. It does also have a little bit of excretion, meaning it gets rid of some of the toxins in the body, like urea and other nitrogen compounds, and it serves a little bit as a protection as well. There's an antibacterial component to sweat as well. The last thing I'm going to talk about as far as accessory structures is the nail. And there's not a lot to say here in anatomy except help you learn a few parts of the nail and areas around the nail. And this is important clinically when you're talking to each other as nurses, or you're giving a report to another nurse, or maybe you're giving a report to a doctor, or those of you who will be, doctors or in the clinical field. You want to know how to communicate. You want to know how to tell someone, where is the red bump? Is it next to the nail, under the nail, beside the nail, beneath the nail? And so we have names for all of these. So I just want to introduce you to these, and you'll need to memorize where these parts are. So if we look at the nail itself, there's really only 3 parts to the nail that you need to know. There's the body of the nail. That's really most of the nail. Then there's the lunula, which is kind of that white part that you can sometimes see right at the base of the nail. If you look through your nail, you'll see kind of a white crescent-shaped structure. That's the lunula. And then there's the free edge. The free edge is just the part that's hanging over the tip of the finger. That's the free edge. So I think that's simple enough to remember. There's a few other parts that you need to know, though. For example, we like to sometimes talk about the lateral nail fold. So that's this area of skin right next to the nail, the part where the nail almost grows into and indents that part of the skin. We call that the lateral nail fold. There's a proximal nail fold as well, so that's going to be the part of the skin right at the base of the nail. So you can also see it there. Excuse me. Then there's the eponychium, or what we call the cuticle most commonly. That's going to be right between the proximal nail fold and the beginning of the nail. Sorry, I kind of covered it over with my circle already, but it's going to be right in that area. So that's the eponychium. And remember, the epi kind of reminds you that it's on top of or above. So it's that cuticle layer just between the proximal nail fold and the body of the nail. And then there's a hyponychium as well, which means below the nail. And so the hyponychium is going to be this area here below the nail. The nail bed and the nail root may sometimes also be talked about. The root of the nail, you can see, is actually quite deep below the surface and almost reaches to the bone, the phalange, or the phalanx. And then the nail bed is going to be, it's hard to see in the picture, but the nail bed is going to be kind of this layer of tissue underneath the nail. So if you've ever had a nail get ripped off or pulled up, the kind of top layer of skin under the nail, it's not really skin, it's a different type of tissue there. If you've ever had a nail ripped up, you know what I'm talking about. It's kind of raw and very vascular. That's the nail bed. A quick word on calluses and scar tissue. So calluses are formed from really a buildup of keratin, and that's because the constant stress, whether it's vibration or often it's pressure. So for example, if you play tennis like I do, I have calluses on my right hand in particular from areas where the the handle from the racket is gripped a little bit more tightly in my hand. Or I also play guitar, for example, and the tips of my fingers on my left hand have calluses, whereas my right hand does not, because I press down on the strings with my left hand. And so the pressure or the vibration over time stimulates basal cells to produce more keratinocytes, and then they produce more keratin, and you end up with a callus. Scar tissue is, what results from healing of a wound, and mostly what scar tissue is composed of is collagen. If you remember when we were talking about types of connective tissue, we talked about collagen as being that toughest type of protein, that triple-stranded protein that was very strong. And so that's good for closing up wounds, because it, kind of keeps it closed and can handle the stress or the force of the two ends pulling on it. The downside of collagen is that it's not very vascular, it's not very flexible, so you don't really have live tissue there in scars because there's not really a blood supply to support living cells. So it ends up just being kind of a plug made largely of collagen. There are several effects of aging on the skin, and this is the last thing I wanted to talk about today. As we get older, there are several things that happen naturally, and I've mentioned a couple already. We talked about wrinkling of the skin. As the dermis begins to thin, we get sagging and wrinkling of the skin. Skin tends to get paler over time. Melanocytes tend to die and produce less melanin, so you may notice as you get older that your skin looks more pale. Or if you look at a picture of your grandparents now and you look at a picture of them when they were 20 years old, you may see a difference in the color of their skin. There are less active hair follicles, and so we tend to have less hair when we get older. That may be in part the reason why we feel colder as we get older. There's also a loss of subcutaneous tissue and fat tissue, and that's probably more why we feel cold, in addition to thyroid changes and other things. But as we get older, we get thinner skin. We also have a less of an ability to repair skin, and so cuts and scrapes and scratches take longer to heal, may become infected more easily than they did before, due to the reduced immunity as well. The epidermis gets thinner. This means we have less production of vitamin D. We have slower repair, as I already mentioned. You have reduced sweat activity. So there's a tendency in older people both to get cold when it's cold outside and to get overheated or too hot when it's hot outside, because they lose some of the thermoregulation. Reduced blood supply also contributes to the reduced healing and the reduced thermoregulation. Skin tends to get drier as sebaceous glands become less active. So here's several things that can occur with aging. Make sure you know a handful of them. They'll probably be part of your exam.